Hey, everybody, we'll get started in
Hey
a few
guys.
minutes.
Just to reiterate, this is super informal. We do not have anything prepared. We do
Yeah,
not have like formal slides prepared like we usually do. Brady uploaded his annotated notes, but
yeah, that's what we're going with this. Okay, so I'm gonna put the link. If you go on the Scrubs drive, what I did was I put all of my lecture notes from last term that I annotate, and I'll show y'all what they look like if y'all haven't seen them before. I color code the information by importance. So if it's red, it's like definitely need to know, green's pretty important, and yellow's important. So since we don't have stuff like really well prepared, if you don't know, we had an exam earlier today, our term 4 exam. But just so if y'all want to go look at what I felt was important going into the exam, it should be basically the same as your notes, except it has my annotations on them. So I put the link in the chat, but it's also on the Scrubs page under additional resources. So if you're in a bind and you're just trying to surf through the lectures to see, maybe look for the red stuff. I try to make sure I remember the red stuff. Yeah.
I don't think we're going to go through everything. We're going to try to make this very high yield for you guys. So if you have something that you really want to talk about, we can do that. But we're going to focus on the things that, because the NB exams, there were certain topics that they hit hard on the exams. And if you didn't understand it, you missed out on a handful of points. And so that's what we're mainly going to focus on today, especially since you guys have a lecture like tomorrow right before the exam.
Yeah. We'll go through. Okay, so yeah, we'll go through the basal ganglia, and then we'll do the eye, and then we'll do the ear, and we'll try to point out the important stuff. A few things that were really high yield on our exam. Obviously, the tracks, the 3 main tracks, the 2 sensory and the 1 motor track. It's really important you can distinguish where the lesion is in the tracks. You're going to be looking at images, so the rights and lefts are flipped, and you got to cross over. So you really need to work on those problems to make sure you get fast with it, because the answer choices are going to be like left corticospinal or right. So like it's very easy to get flipped around. I think I mentioned this last time, like the strikeout function on the key, in ExamSolve is really helpful, because as you read the stem, you can cross off things. Like remember, if it's a lesion in the brain, everything's crossed. Like don't make it harder than it needs to be. So yeah, once you pass that point, and at least for the lower, the nerves that go to the body, not necessarily the face, but the ones that go to the body, once you cross that lower aspect of the brainstem, the medulla, everything's crossed, right? So think of it like that. If you have a lesion in the internal capsule or somewhere up in the primary sensory or motor cortex, then everything is crossed already. The tricky ones are where you're trying to figure out in between where the DCML and the cortical spinal tract cross, and obviously the ALS crosses at the beginning. Another thing that they had a bunch of questions on that was kind of strange is lower motor neurons. Right, so remember that the cell body of the lower motor neuron is in the gray matter of the spinal cord, right? And radiculopathy is a fancy way of saying you have a pinched nerve. So if you have a pinched nerve or radiculopathy, you're going to get lower motor neuron symptoms, okay? It was one of those things, it was just like, there was like 6 questions on it, and it was like, if you didn't just happen to come across that, you might have like really messed up. So remember, like, that part of the anterior horn contains a cell body. The upper motor neuron is going to come all the way down. It's going to cross over. It's going to attach to the cell body on the ipsilateral side. The lower motor neuron is going to come out at the level of the vertebrae, right? We discussed a lot of the posturing, so that's important. So besides the 3 main tracks, in regards to the extensor and the flexor tracks, they use the posturing as a good example of how to test it, right? So if the lesion's above the red nucleus, that means that the rubrospinal tract is intact, right? So that's why you get flexion. If it's below the red nucleus, the rubrospinal tract is knocked out. So all you have is the extensor tracts that are intact, which is like the vestibulo. There's a chart about it. So keep that in mind. But other than that, those tracts aren't super high yield, just the three main ones. Yes, I saw the Lissauer's tract. We covered that in the last one. Just remember, wherever the lesion is, the symptoms are 2 levels within it, right? Up and down. So if you have a lesion from T2 to T10, you'll feel symptoms from T4 to T8. We covered that in the last one too. Make sure you could do that backwards too, right? So if they tell you you have symptoms from T4 to T8, that means the lesions from T2 to T10, right? It works both ways. Where's the lesion? Symptoms are always smaller than the lesion. Let me pull up the chat, see. Random, I'm not sure what you're referring to.
The middle ear box.
The middle ear box, oh, 100% important. Yeah, you have to know that. Yes, we'll look at that. I'll show you. It's not as bad as you think it is. Remind me, or we'll get to it. Okay, let's just do this. I'm gonna go ahead and share my screen, and we'll start with the basal ganglia and go from there. And then y'all just cut me off and whoops. Y'all could just cut me off and where'd everybody go? Because I can't see the chat right now. So, right, so just a few things here. This gets really tricky. Okay, first of all, this is how I do my notes. So if you wanna get access to these, they're on my drive. I went ahead and put them on there. So like red, super important, a lot of keywords that come up. Green is important, that has correlations, and then yellow is kind of also important. I don't highlight all the slides like this one, but like, it helps me organize in my mind what's going on. So remember, there are 2 pathways. They're dopaminergic pathways. So the thing about the brainstem, you have 3 major that I could think of problems, right, that can arise from this. So if in the substantia nigra, you have Parkinson's, right? So you get a resting tremor. What does that mean? So it means the patient, when he's at rest, he's shaking. If you tell the patient to touch your finger, right, he'll shake before he starts, but as he goes to touch your finger, the tremor goes away. That's defined as a resting tremor. When he has an action, that's when the tremor goes away. So it's important because they won't just tell you it's a resting tremor. They'll tell you he has a tremor when he's not moving, or as he starts to perform some sort of action, the tremor goes away. So that's Parkinson's. Now, quickly, if you compare that to some sort of cerebellar problem, they have an intention tremor. So if it's exact opposite. If they're still, they're not going to have a tremor. But if you tell the patient to touch your finger, as the patient gets close to your finger, their hand's going to shake, and they may start what's called pass pointing, go around it because they can't comprehend, or without the cerebellum, their place in space. The way I think of the cerebellum is it fine tunes the rest of the brain, right? So little movements, little repetitive movements, stuff like that. So keep that in mind. Also remember that cerebellum, the tracks, they don't cross, right? Everything at cerebellar is ipsilateral. So that's a big difference from the cerebrum. Okay, so this is very confusing. If it's blue, it has a positive signal. If it's red, it has a negative signal. See the neostriatum signaling here? So if it sends a negative signal here, then this signal is going to be absent. So that means this is going to give a positive signal here. It's a lot of confusion, and you don't need to write this out on the test. So my point would be is that the dopamine 1 pathway is direct, and it facilitates movement. It allows you to move. And the D2 is the indirect pathway, and it inhibits movement. So I know these blue slides are really wordy, but you can gain a lot of information from them, a lot of understanding to help with the questions. So Parkinson's is considered a hypokinetic disorder, right? So everything is slowed. When the patient tries to move, it's hard for them to get up. Everything takes extra effort, and that's because you don't have the available dopamine to get moving. So again, if you look at this D1 pathway, the whole goal is to get positive movement to the thalamus, so the thalamus can move, can help with movement. And then the negative pathway takes a little bit longer track, and it goes and it's going to inhibit movement. Okay, the subthalamic nucleus that is related to hemibolismus. The defining characteristic of hemibolismus is that it is unilateral. So they'll tell you that one arm is flailing, right? One side is has the movement. That's distinguishing from Huntington's disease, right? Remember, Huntington's, you need to be able to identify the caudate nucleus on scans because it's going to relate to Huntington's disease, right? So it had choreiform movements or dance-like movements, and it's bilateral. So those are the three that you're worried about with the basal ganglia: Parkinson's, hemibolismus, and Huntington's, right? And then
on the Parkinson's.
Yes.
Since we're knocking out the dopamine, we're knocking out both D1 and D2. So we're knocking out something that helps with movement, but we're also knocking out something that stops the movement. So how do we like make that separate? Do we just know that since we're knocking out the direct pathway that things are getting slowed more so?
Yeah, I see what you're saying. I think it's a lot more complicated than we get into, here. But if you think about it, like if you don't have the dopamine initially to activate movement, then what are you inhibiting in general, right? There's nothing to actually inhibit, right? If you don't have that D1 pathway, then there's nothing for the D2 pathway to help inhibit. So the dopamine's kind of like gas in a car. There's no point in putting a red light there if there's no gas in the car, right? You're not going to go anywhere.
To answer your question, I think D1 is purpose movement and D2 will inhibit the ones that are not needed. And when that is knocked out, the patient will have unpurposeful movements.
Okay. But that would make it a hyperkinesis.
Right. So I think the overall point is if you don't have dopamine in general, there's lack of movement overall. Like what exactly would you be inhibiting if there's no dopamine there to begin with?
Okay,
right.
Thank you.
And that relates all to the hypokinesis of it, the fact that everything takes action. But understand, it's not a complete absence of movement. They do have that resting tremor, right? So it's just kind of haywire. But I don't think we really need to get into it in that much detail. I don't know it in that much detail, to be completely honest with you. But
the biggest things to understand are the GPL, the GPM, the medial and lateral thing. Those are really big in when you're talking about the pathologies. And if you guys have osmosis, they have some really good high yield notes on it that I think makes a lot of sense, and their video makes a lot of sense. So anyone that subscribes to that, I would go look at that. But it's the globus pallidus internus, whatever it's called. Those are the big things you need to understand there. They'll ask a handful of questions on those.
Okay, right. And so, yeah, a little bit more to your question. So if you're going to insufficient release of dopamine will infect both pathways, right? So, yeah.
Is there a specific name for that type of movement for Parkinson's where you have?
I can barely hear you, buddy.
Is there a specific name for that type of tremor that like corrects itself?
Yeah, it's called a resting tremor. The Parkinsonian tremor is a resting tremor.
Okay,
yeah. So when they're moving, they're fine. It's when they're still that they have the pathway. So yeah. So right. Okay. Yeah, but as long as you can identify that, I don't think they'll go into too much detail on Parkinson's. But again, these blue slides, they do have a lot of information. So like, see, this is why I would put this in red. So this is something that I kind of feel like would be a good test question, right? What's forming from these Lewy bodies and stuff like that. Lewy body dementia is, if I remember correctly, is very similar to Parkinson's, or is it Alzheimer's? It's Lewy body dimensions like Parkinson's, I believe. Yeah, it must be, because this is the slide. Yeah, so it's like a precursor, it's a variant of it. I would be able to identify these. Remember, you see the substantia nigra is the dark area here. You can see it fading here. So that I would be able to identify that, so you can identify Parkinson's. It is specifically the reticulata, I believe, but I don't think they would get into that much detail. Okay, yes.
Like for that
What's
one.
up? What's
I
up?
think it's the active.
Is it? Okay. Significant
Yeah.
reduction in pigmentation of, okay. Yeah, if y'all say so, yeah. Pars compacta, okay. Yeah, but it's, as long as you know it's a substantia nigra, it should be okay. Right, all this defines as hypokinesis, right? Resting tremor. So remember, like I said, when that patient has to perform an action, the tremor goes away. That's very different from a cerebellar problem where they say, can you perform this action? And they can't, right? The tremor starts up. That's an intention tremor. Okay, I don't think you really need to go into the different phases of it. So medication-wise, it is important. They give carbidopa. It prevents L-dopa from being broken down until it gets into the CNS. So carbidopa will stay in the PNS, and once L-dopa crosses the blood-brain barrier, then it's able to be activated, right? So carbidopa will prevent it, because if you don't have carbidopa, L-dopa will be broken down in the peripheral system. So that's why they add that. You have to have carbidopa with it for it to work properly. Let's see. Yeah, we kind of talked about Huntington's. Again, I hope they put a picture. Yeah, so you could see right here, that's your caudate, right? It's right along the eyeballs, the lateral ventricle. So if that atrophies, make sure you can identify that. They could point to it and maybe ask a second order question like, what is the problem that's forming? So it's atrophy, it's enlargement of the ventricles. Why? Because the caudate's right up against it. So, and that's diagnostic for Huntington's, right? And this is more of a hyperkinetic movement, right? Flailing arms. Remember I said it is bilateral. Okay, so a reduced inhibition of the thalamus, right? So if you decrease the indirect pathway, you're going to have purposeful movements or intentional movements. Yeah, and if you haven't seen Korea, you could look it up on YouTube. It's considered like dance-like movements. It's like it's not as flailing as hemibolismus. It's more of like a rhythmic type movement. Okay, right. Okay, so let's talk about hemibolismus. Again, one side of the body. It is unilateral, subthalamic nucleus. Right, so if you knock that out, then you're going to get another, it's going to also be a hyperkinetic problem. Right, and you can see that here. This is a good little, oh, also, by the way, this is my little stars are important slides. I end up, anytime I put a star on the slide, I end up printing them as like shorthand notes. So if you see a star up there, that means at some point I decided that would be important. Okay, if y'all, let me just show y'all. So if y'all go to the term 2 stuff under additional resources, I put NB1 lectures. These are for the entire NB1. I put all my lectures up and they're all my annotations. So I know the test is on Wednesday, but if you're just hung up on something, you can go and see what I felt was important. Okay, so cerebellar problems, we can just try to point out a few things. I did mention it's ipsilateral, right? So if they have some sort of intention tremor on the right side, that means there's a lesion on the right side, right? Some things that they like to talk about the cerebellum is dysdiadochokinesia. It's a really long word. So you're not, I believe it's rhythmic movements, sort of like patterned movements. So that's one they talk about. I think there's a few more. Give me 1 second. Okay. Knowing these lobes is important too. It was a little tricky, but the anterior lobe is more of the trunk, right? And then the posterior has more of movements of the limbs. And then the flocculonodular integrates the vestibular or the balance apparatus. So it's a little tricky there.
I had another quick question.
Yeah, talk up for me. I could barely hear you.
I think it's my mic. It's kind of.
It's okay.
So the anterior, would you say that that's more concerned with the walking, and then the posterior, the cerebrocerebellum posterior part is more like the precise movement. So you're going to get that diatokinesia, and then the
Yeah,
the far, what's it called? I forgot. I'm spacing out on it.
I think there were three. I'm so tired. I don't know, but there were three things. It was like dysdiadochokinesia. Do you remember, Lindsay? Pass pointing,
Yeah, the
Pass pointing,
dysarthria and the dysynergy.
dysynergy.
Yeah,
That's it.
I
Yeah. All the
I honestly
Ds.
didn't hear that question very well.
It's
Sorry,
okay.
the mic is off, Fubar.
It's okay. Yeah. So we're going on lag because y'all know how it is. So anterior lobe, I would consider it postural. Yeah, maybe not walking because you include the limbs, but postural. And then posterior lobe, if they talk about some sort of fine finger movements and stuff, I would definitely consider posterior lobe, something on the extremities, right? Anterior lobe maybe more primitive, more, postural, more upright, and posterior is more integrated, as it says, right? So precise movements. And then flocculonodular lobe. I'm not cursing at y'all. You too.
Yeah.
All right. Is balance, right? Balance and integration, right? Again, it stays ipsilateral.
If you are having a hard time visualizing the lobes, if you have physio, they have a textbook thing and they have a lot of really good pictures in there. There's a really good cerebellum picture that helped me because I don't know why, but the pictures in the slides, I just couldn't visualize it really well. But those pictures are really, really good in the physio notes.
So this outlines it pretty well. So something with anterior lobe, if they talk about problems with, like you were saying, like walking or being able to stand upright. So if you're lurching to the side of the lesion, it would be an ipsilateral lesion to that side probably. Apparently malnutrition, chronic alcoholism, probably some sort of vitamin deficiency is involved there. And then, here we go. Dysarthria, right? So just dysynergy, dysdiadochokinesia. So that's like when they say like tap twice on each side. And then dysmetria is like when you tell a patient, you say, okay, touch my finger. And they don't have a tremor, but as they start to go and touch your finger, they start to shake, right? And they go past it. So along with the parietal lobe, the cerebellum has a lot to do with being able to stop and start intention. So it's very complex, and your place in space as well, right? It has a lot to do with proprioception. And then, of course, any sort of nystagmus, when you think of nystagmus, you should think of something wrong with the vestibular system. So this isn't directly related to the vestibular apparatus with cranial nerve 8, but those fibers do go to the cerebellum to help fine tune your movements when you talk about some sort of balancing, or like tandem walking is a good example, or truncal ataxia could be a problem because you're not able to stand upright, like your place in space, where your head's at in space and stuff. Tumors, I don't think they talked about tumors. So like just because it's red doesn't mean I didn't go back after the test and mark this as test questions or anything. This is just as I was going along, like, oh, that could be a good test question. So like, I didn't go back after. So it doesn't necessarily mean it was tested. It's just like, as we were doing it, I was like, I probably should remember that.
You definitely need to know the arteries, what's associated with it. Make a list for yourself of all of the arteries and what the main thing is that is affected. It might not have been the biggest thing in NB1, but moving forward, it'll be a really, really big thing. But if you just know a couple things that are associated with each of those arteries, you'll get those questions right.
Okay, so so cerebellar degeneration with alcoholism.
Kind of been a thing.
There it is. And then B1 deficiency, sure. Yeah. So like Wernicke-Korsakoff, when they talk about that, all the symptoms that go along with Wernicke's, like the ophthalmoplegia, right? Confusion, and then Wernicke's is the confabulations, right? They make up stories. I don't remember this being on the test, but these are related. You talked about this in FTM, ataxia telangiectasia. So There's the telangiectasias. You can see those there. Is that it? So what we should do, again, this is very informal. So like, if y'all have specific questions, we can go through that. But this is Dr. Haig's lecture that like there's like no words on it, which is great to figure stuff out. So
I actually have a question, because like I did the Gray's problems that are part of like these lectures, and they're all about like fractured eye orbitals and like where bones are going to go, or what vein or nerve is like damaged from being, you know, hit and breaking the socket. Like, is that on the exam? Because I went through them and I'm like, we didn't learn anything about how those break.
yeah,
Go through Gray's.
yeah, for sure. And it'll be more important when you get to the second exam, because you have to know where all of the cranial nerves travel. So that's going to be really important to do the Grays, because it's going to correlate a lot better. But I think they're fair game for this too. Yeah, I would make sure you do them. Development wise, I don't think it was super important, but like the retinal fissure relates to that keyhole iris or the keyhole pupil. So that's something that I believe was tested.
Real quick, a big thing that you need to know, slide number for us, it was 9, where it says openings for their content. So superior orbital fissure, oh my God, superior orbital fissure, inferior optic canal. You need to know what goes through there, because they'll test that and it'll be a couple of questions, but those are easy questions if you can get it.
Okay, and
Yeah,
now
just
that
for anybody
no, go ahead.
that didn't do Grays, there was a ton of questions over that and like the whole keyhole iris thing.
Thank you. I want to point this out. So anything related to cranial nerve 3, because this is going to be a common theme that comes up. Cranial nerve 3 often injured with some sort of uncal herniation, right? If you have some sort of hemorrhage, like an epidural hemorrhage, and you get the uncal herniation and it compresses cranial nerve 3. Remember, there's 3 components, right? So you have the eye is going to be down and out always, okay? So that's because if you affect cranial nerve 3, the vast majority of the muscles of the eye won't work. So the eye is going to be down and out. The lateral rectus and the superior oblique are the only ones that work. That's because cranial nerve 4 and 6 are still intact. So with only those 2 eye muscles working, the eye will be down and out. So that's the muscular component, or the ocular motor nerve component. But remember that parasympathetics travel with the ocular motor. So along with being down and out, the eye will also be dilated. Okay, because you knock out parasympathetics. And if you knock out parasympathetics, you have unopposed sympathetics. Also, there'll be slight ptosis, which means that you'll have unilateral, the lid will be kind of down. I think it's the levator palpebrae, correct me if I'm wrong. That's the muscle that's injured, because that nerve travels with the cranial nerve 3 too. So whenever you see down and out, the eye down and out, remember that the pupil is going to be dilated, and the lid, you're going to have lidtosis. Also, obviously, if you have an abducens problem, right, that only controls the lateral rectus. So if the lateral rectus is knocked out, then the eye is going to be medially rotated, right? Because you have that muscle's not going to work, so you have unopposed in the other direction. Okay, so the lateral rectus pulls the eye out. They don't really talk about a trochlear nerve lesion for whatever reason. They don't really mention it. I don't know, actually. It's either up and in or up and down. If there's a trochlear, somebody could, if they know. If it's an isolated trochlear injury, it must be up and in and up, but don't quote me on that. They don't talk
out.
It out and up.
It's if you have trochlear issues, then your LR6 is taking over, so your abducens is working, and that's going to be up and out.
Up and out. Okay. So don't get that confused with, they don't talk about that much, but don't get that confused with down and out, because that's going to be oculomotor. Also, they like that fracture question. So if you get a fracture at the lower point of the orbit, it's different from having muscle injury, right? So if you injure the, okay, so let me put it this way. So if you have a fracture at the lower point, the inferior rectus can get trapped, right? So if you're holding on to the inferior rectus, the eye's not going to be able to look up, right? So don't get that confused, because if it's trapped, it's kind of pinching the muscle from allowing it to move. So don't get that confused, because that's not necessarily a nerve injury, it's a muscle impingement. I know y'all had questions on that.
The whole walking down the stairs thing there were like 2 or 3 questions on that.
You can
FYI.
more than welcome to. I don't remember how they went. Do you remember?
So like patient walks down the stairs, so you have to put your eyes in and down. What's the problem? And it's the trochlear nerve.
Oh, yeah, that's a good
Yeah,
point.
superior
Okay, good.
oblique. They had a few questions on
Yes.
that, honestly.
That was in the grades, in the one of the questions.
Yeah, there are a
Okay,
couple
sweet.
of those on there.
Like, this is one of those tests where, like, try to focus on the screen, like, don't look off, but like,
Oh my God, yeah.
you're gonna be like moving your eyes around, like trying to figure out what's going on, right? So like trying to like orient
Yeah.
yourself in left and rights, but
Yeah, there were a fair amount of questions that you did have to understand the eye movements, but when you get those down, it should be pretty easy. So they'll, medial versus lateral rectus. What I do is I keep my hand on the screen and I use my fingers to do the eye movements so I don't get flagged.
Yeah.
But there are a fair number of those questions. So if you get that down, you'll get a handful right. So make sure you understand that.
Did y'all do corneal reflex, or is that for next exam?
I think that's tomorrow.
That's tomorrow. Okay, we're going to discuss that. I want to talk about this first. Yeah, I want to talk about this. So remember, when you're doing the H test, you want to be able to isolate, like this is an important slide, you have stars on them. You want to be able to isolate a muscle to try to see if you can identify what's going on. So remember, when you do the H test, what you're testing in one eye is not what you're testing. What you're testing in the right eye is not what you're testing in the left eye, right? So if you're able to move your eye, so this would be that's the right eye moving. So yeah, to the out, right? Because this is lateral rectus. So if you tell the patient to look outward, and this is, let's assume this is the right eye, right? Right eye looking out. When you look up, you're testing the superior rectus. You're trying to isolate it. When you look down, you're testing the inferior rectus. So that makes sense. Superior rectus up top, inferior rectus down low. By moving, you test the lateral rectus by moving outward. Then once it's isolated like that, you can look up to test the superior rectus. You can look down to test the inferior rectus. Now, it's opposite if the eye is looking nasally, okay? So we could say it as temporally when you're looking out, or nasally when you're looking in. When you're looking towards the nose, right? That initial movement towards the nose is to the medial rectus, all right? Cool, that works if you could look towards the nose. Now you're trying to isolate it by looking up or down, but these are flipped, okay? Just because of the positions and how they're situated behind the eye. So once you look nasally, right? Medial rectus, when you look up, you're testing the inferior oblique. That's because the inferior oblique's kind of pulling the eye from the bottom, right? And looking upward, because it actually attaches behind the eyeball. So it's tweaking it up. And then if you look down, if you're looking nasally and look down, you're testing the superior oblique. So basically, if you think about it, everything kind of makes sense, but just be aware that the inferior oblique and superior oblique are flipped, right? So this is a super important slide. They could definitely ask you like this, and they could ask you, they could ask you specifically, what muscle are you testing by looking out and up? Out and up, easy, superior rectus. In and up, inferior oblique. Yep, what's up?
So like, I understand, like, say if the right eye you're looking like down and left, or down and out, that's like the inferior rectus. But what if, like the way I see it too, are you also testing is the lateral rectus also being activated if you're using the inferior rectus? If you're looking down and out, doesn't that activate both inferior and lateral rectus?
Right, exactly. But
our purposes, just like sorry, go on.
So yeah, no, good point. The point of the H test is that you look out first. So by looking out, you're testing the lateral rectus. So the initial movement of the line on the H will test that lateral rectus, but then it's isolated and contracted. So then you could say lateral rectus is intact. Then you move up from that outward position. You look straight up or you look straight down. So that initial movement of the H to the side is going to test the lateral rectus. So yes, you're right, it is contracted, but once you get to that point where you're looking, temporally, you're assuming it's intact and you can actually isolate these to see if they work.
That makes sense. So like that's the distinction between like them asking, what are you testing versus what muscles are activated?
Yeah,
kind of thing.
exactly. Right. Okay. And then this will help you kind of, again, make sure you identify in the question, are they asking you what muscle is being tested or which muscle is deficient, right? So happily, gladly, lateral rectus is usually the one they use, which is great because it looks outward, it's one muscle, you're good to go. This is, again, like you hit this really hard in NB2, but
you do need to know it for NB1 though. They'll have 1 or 2 questions and it's easy points if you know it, but
yeah, some of them come back because you start talking about the face and like how never mind. Yeah, just know what's here. Cavernous sinus is a good place. It's a good conduit for infections, right? So any sort of venous congestion or venous infection it's a good place to know what actually lives in the cavernous sinus. Yeah, we talked about this in the first review. So, right. So, here's it. Oh, they did put this, which is really tricky. If you have some sort of problem with the interior carotid artery, some sort of dilation or an aneurysm in the internal carotid artery in the cavernous sinus, what nerve is affected first? And you're like, what the hell are you talking about? Well, as it is, cranial nerve 6 is the one that lies closest to the internal carotid artery. Okay, so easy points there. So if you have so they can make it a second or third order question. If you have some sort of dilation of the internal carotid artery in the cavernous sinus, what's the eye going to be presented like, right? So dilation, the first nerve's affected, cranial nerve 6, that would affect your lateral rectus, means the eye would be medially deviated, ipsilaterally, right? Because the cranial nerves don't cross. Yeah, they did ask that. So 6. Let's see. Y'all will get into this in much more detail in the second one. You have to know where all the ganglion and everything goes. Like was mentioned, the keyhole pupil that was on there. So definitely know that. The sty, didn't we have one like that? Where like, where does sty come from?
Yeah, the difference between the sty and the other one, it was whatever gland it
was. Which one involves a hair cell? Is it the other one?
That's the sty, because
sty, okay.
Island with the eyelashes.
Okay.
It's the name of the gland. There's a certain name.
The Meibomian cyst.
Yes.
I was about to say Bartholian. Isn't that in the vagina? I think.
Yes.
Yeah, it is.
My bad. Don't get a style there. There you go. All right. Let's talk about. Okay. Tricky stuff. I'm gonna try to point out. Look, this is a good slide to know. I think they have one like this, but it's labeled. Like knowing the different areas, right? The cornea is clear. The lens, understanding so the lens is going, well, we'll get there when we get there. Okay, so like, knowing these different landmarks are important. So they could definitely put this on there. I believe we had one that was low mag like this. The ciliary bodies, remember and the canalish slim is going to be where that ocular fluid is going to be made. Okay, this is super important. Unfortunately, you have to know the layers of these. Whatever you need to do to remember, where is it? I know that, oh yeah, here it is. To remember the layers, you need to do it. Most importantly, is it between layers 9 and 10 or that where you get a retinal detachment? Anybody?
Yes, that's right.
1 and 2.
1 and 2. So I guess it depends which way you're counting, but it's the more posterior aspect of the eye, right? So it's in between this the pigment cells and the rods and cones, I believe. So definitely know that, but I believe they did ask some funky questions, like just pointing to something. I might actually, oh, here we go. We could talk about this. Let me just check something real quick. Didn't they put like one big slide with it all labeled? Here it is.
Yeah.
And this might be from, it might be labeled from small group or something. Yeah, so between layers 1 and 2 right here, or if you count the other way, but the point is, yeah, so understand this. So like this is the inside of the eyeball, right? So light is coming from where my pointer is through the eye this way. It goes through all this stuff, then it gets to the rods and cones, and then it gets to the pigment layer. So this is the back of the eyeball. Okay, so yeah, if you get a detachment, it's just the way that the cells are lined up. They're kind of pressed against each other, so it's an easy point for detachment. But let's go back real quick. So it's very, oh, here, this is kind of a cartoon. Oh, here's good, yeah. Know this, right? So these different layers. Yeah, that's a tricky one. Here's another one, same thing. Yeah, here it is. Pigment layer and the rods and cones. That's where you get this retinal detachment. I wanted to talk about.
Real quick, make sure you understand the orientation of all of the layers with respect to just the eye in general, because that can help you on some cues. Because when you're looking at these things up close, it's really hard to orient yourself to this is where the aqueous humor is. This is, you know, the different locations and compartments. Make sure you understand that, because when they start throwing out these terms on the exam, if you don't understand their relationship, you'll get really confused and it'll mess you up on a couple questions. So make sure you do spend some time on that.
Okay, so this is tricky. So accommodation is the ability to contract or relax the lens to try to look at near vision and far vision. So these were flipped, actually. I had to correct this. I hope they corrected this for y'all. Sure, actually, no, it's not. I might have messed up there. Actually, don't even look at this. We could just talk about it. I might, wait, ciliary muscles relaxed, tightened. That is not that. Let's do this. Okay. Okay, so let's talk about this. I think I got crazy one night and confused myself. There we go. All right, so whatever the ciliary muscles do is going to be opposite what the lens does. So it's just because of their orientation, they're oriented in a way to where when they're relaxed, it tightens the zonula fibers. And when you tighten the zonula fibers, it pulls the lens flat. When the lens is flat, you could see far. So that's sympathetic. You want to see far, you're running from a bear, you want to see where you're going. Now, if the ciliary muscles are contracted, that means the zonula fibers are relaxed. And if the zonula fibers are relaxed, the lens is more rounded. As you can see here, it helps to divert your attention, your focus to something close up. So this is more parasympathetic, right? So just remember, the way I heard somebody say it kind of clicked to me. If you held a rubber band and you just pinch the ends, the rubber band kind of loosens up in the middle, right? And that's kind of like how the ciliary muscles are oriented. They're pressing in a different direction that make the zonula fibers relaxed. So, and if they're relaxed, that means the lens is going to have less tension so it can bulge up. And when it bulges up, it can see close. So make sure you can orient that. If you do look at my notes, make sure you correct that slide. I don't know what happened. It was a late night, I'm sure. Glaucoma is kind of important. Yeah.
Do you mind just going back? So you said like when it's further, it's sympathetic?
Right, yes. So the sympathetic,
like if you look at the pupil, it says the pupil is constricted. If the pupil is constricted, wouldn't that be parasympathetic?
That must have been why I had all those lines messed up on my yeah. I mean, correct me if I'm wrong, Lindsey. That's right. When that should be switched. Maybe that's why I got all confused. Because when you're
from ours, like
they
it's not
removed
even
it. That's why. Okay, so if you wanted to correct this, this should say dilated and this should say constricted. That's probably where I got confused looking at this. Yes, so that this is incorrect. yes, when you're looking far, all this is right, but you would also have dilation of the pupil. So I'm sure that's why they took it out. I probably sat there for a couple hours trying to figure this out and it confused the hell out of me. Yeah, so right. So everything I said is true. And then you take the pupil into account. This pupil should be dilated, right? Because it's sympathetic. You're looking far out. And then this pupil should be constricted because you're parasympathetic, you're looking close, near vision.
And you're testing coronary nerve number 3, right? The oculomotor?
So yes, right, yes. So yeah, because you're dealing with, and it has a lot to do with the autonomics too, which I don't think y'all really need to get into. But yeah, in regards to oculomotor, you're testing the parasympathetic branch, which just travels with it. So that's going to deal with the dilation and constriction of the pupil. Yeah, and then there's some autonomics like the M3 has to do with that as well. But that's term 4. Y'all can deal with that. All right, so y'all got this. Make sure you know this. Unfortunately, you got to know them all. Rods and cones, y'all should be good with. Yeah, rods, night vision, right? Darkness. Cones are colors. I think there was something important, like about their orientation. Isn't like, are the cones are located centrally, right? Is that right? Yeah, that was it. Cones are located centrally. Yeah, again, pigment layer and layer rods and cones, for sure know that. Okay, yeah, so another good imaging, right? So that optic disc, right, and the fovea centralis. Oh, here we go. This may be a neuro 2 problem, but you need to be able to orient yourself, like say what eye this is. So if you look here, wherever the optic disc is, or wherever the vessels you see here, that's nasally, okay? Again, this might be a neuro 2 problem, but I'll just point it out right here. So if you orient yourself, this would be the right eye, right? You'd have to turn around and, but this is gonna be toward the nasal side, okay? So that would be the right eye in the patient.
That will be important in a couple of questions to orient yourself, just to let you know.
Actually, it says it down here, so you're good to go.
That is really important.
Yeah.
Don't
So
blow over that.
Wherever the vessel is, the optic disc. Remember, you can't see at the optic disc. That makes sense because there's a bunch of vessels there. That's why you don't have, it's kind of convenient, you don't have vessels in your center of vision because that would obstruct your vision. So that's where the fovea is, that's your center of vision. Again, that's going to be a lot of cones, right, for the color vision. All right. Oh, this is that stuff we were talking about. Yeah. The key, yeah, whatever that word is. Okay, whatever. Okay. All right, let's see what else. That's it. Chalazy. All right. All right, we should talk about, that's not that important. Is this a DLA?
What one is that?
I don't know. Visual.
There.
No. Oh, it's the retina
visual
stuff.
System.
Okay,
Retina.
we kind of talked about the retina.
Oh wait, hold on. Let me.
Oh, so these definitions are very important.
Oh yes, please memorize those.
Yeah, and like try to work out in your head like what this means, because at least for me, it kind of seems backwards the way when you correct the lenses, right? Because I think Dr. Mandolanini, or you know what I mean. You know, they can ask you how to correct it, right? Concave, right? You want a concave lens because it's going to bring your focal point inward, right? So sorry, nope. Myopia is going to mean you see right here, and a corrected lens is going to bring it back to the back of the eyeball. Okay.
Oh, this is a high yield lecture.
So myopia means you could see near. Is it near vision? Yeah, nearsightedness, right? So yeah, so you see close. So if you want to correct it, you have to put a concave lens because that's going to push the light outward and then come back in at the correct point. Okay, so maybe draw that out. Now, if you see too far hyperopia or farsightedness, right? So you want to do a convex lens, right? And that's going to bring that point back to where it needs to be for you to see properly. So make sure you get this nomenclature correct. Here's a
There were
slide
like
for
2
you.
questions on this, FYI.
Yeah, for sure. So not only what it is, but what kind of correction, what kind of lens would be a good correction or the right correction. We kind of discussed this, right? So parasympathetic.
This lecture is actually pretty high yield, guys. Make sure you pay attention to it. Autonomic control of the people. This is big, big, big.
Right. Okay. I guess we should go. Y'all did pupillary reflex then, if this is that. Right. Okay. So when you shine the light in the eye, we should probably go through a practice question with this to make it easier. But if you shine the light in one eye, right, you expect it to dilate, but you also expect a consensual response to the other side. So being able to differentiate if it's some sort of motor problem in the eye you're shining it in, or is it a sensory problem in the eye, or is it going to be a motor problem in the other eye? You need to be able to differentiate that. If y'all
I remember a long discussion about one of the practice questions in our chat, so make sure you understand this really well.
If y'all have any good practice questions, y'all could send them to me real quick and we can look at them just to work through it, because you need to be able to do the pupillary response to see what's going on, and you need to be, well, y'all haven't done the, I'd like to do the corneal reflex since y'all are doing it tomorrow, because it kind of works the same way.
But once you get it, it's easy. Like once you get it and it's fine and you can get all the questions, right? But so it's not something that takes a long time. Or
did you guys have any questions on like rhodopsin, dark current, all that jazz?
Oh, the only thing I remember from that, I remember it being tricky because in dark current, it's activated, right? Is it in this? Did I pass it up? And
that was on the DLA.
Okay, it's this too, right? So it's it's weird because you would think when it's dark, this would not be activated, but it is in dark current. So when you have light, it actually inactivates it. So you block the sodium channel. So everything's backwards from what you would think. When it's dark, you're actually getting transduction. You're getting sodium in this pathway. And then when there's light, it'll block the pathway and turn it off. So besides that, I think that was the most complicated thing that they went into. I don't remember them going into this in too much detail. Maybe know these definitions too. For some reason, I remember long waves. Yeah. Okay. Is this the reflex thing?
What lecture is that long wave? I haven't seen those slides.
Oh, this is from my stuff from last term. So 25, it's our 25. If y'all didn't do that, don't worry about it.
Yeah, visual system retina, that's what it's called.
Yeah, if y'all don't have it up, by all means, don't worry about it. Okay, this makes sense, right? Meiosis, mydriasis. The bigger the word, right? So meiosis means constricted because it's a small word. Mydriasis means dilation because it's a big word. And then knowing the dilator pupillae, that makes sense because it dilates. The sphincter pupillae closes it up, right? Edinger-Westphal, that's where cranial nerve 3 goes. That's, y'all probably need to know it now, but definitely next time. Horner syndrome, so you get that triad of symptoms. Remember, if you knock out the sympathetics, you get ptosis, anhidrosis, which is decreased sweating, and pupillary
Horner's
constriction.
comes back a couple times.
Yeah, for sure. So make sure you know that triad of symptoms, and the point is
It
you're
won't call
knocking
it
out
Horner's though,
sympathetics.
you just have to recognize it.
Yeah. Okay, that was that. And if y'all find a good question to do the reflexes, we could definitely look at that. So, all right. So this is tricky, but all you need to do, well, all you need to do is Once you get to the retina, the tracks make sense, right? So the point is, in the eyeball, everything's flipped on the retina. So whatever is up and out is down and in, right? So if you have some sort of visual problem in the outer aspect of the eye, remember in the retina, it has to go to the lower inner aspect. Once you get to the retina, you're good to go. Everything on the inside part of the eye is going to cross, okay? So the clinical scenario they talk about is some sort of pituitary tumor. Why? Excuse me, because the pituitary tumor or the pituitary, if it's enlarged, will press on the optic chiasm. Now, if you know that these middle, the ones that travel in the middle right here are going to be the ones that cross. Let me find a better picture. There is one, maybe not. I thought he had some that he did practice. Okay, here we go. Yeah, perfect. Okay, so once you get to, this is the eye, this is the retina. Once you get to the retina, everything makes sense. So the inner aspect is going to be what crosses, the inner aspect. Remember, the inner aspect of the eye correlates to the, I'm sorry, the inner aspect of the retina correlates to the outer aspect of the eye, right? So if you have some sort of lesion, the pituitary tumor, it will be tested. You're affecting that middle part, the fibers that cross. The fibers that cross were on the inside of the retina that correlates to the outside of the eye. It's called bitemporal hemianopia. That means temporal, your your temporal lobe, your temples, whatever you need to remember it by. Right, so your outer aspects of the eye. The opposite is binasal, right? So binasal is intact. It's bitemporal. So that's a good test question. Now you can, and you should be able to go through these. You should be able to go through all of these. So if you have a lesion in the optic tract, right? So it didn't get to the brain yet, which is important. That means you have a lesion here. So you need to know what fibers are going to travel in the optic tract. Well, this outer aspect of the retina here didn't cross. What does that correlate? The inner aspect of the eye. That's what makes it tricky. You have to remember that extra step. So remember, let's go from the eye. If light comes in on the inside, it's going to go to the outer aspect of the retina. Now from there you go. And because it's not on the inside, it's on the outside, it doesn't cross, it stays, okay? Now this part, the outer aspect of the eye correlates to the inner aspect of the retina. Remember we said the inside crosses. And then if that's the case, then everything there is going to, if you have a lesion there, that's going to affect those, right? So then that's what it correlates. So you should kind of be able to draw it out in your mind to try to figure that out. Oh, cool. Somebody sent another question. All right. Let's see. And then you can take it another step further and you could break it into quadrants. So now what you need to integrate is the Myers loop and the temporal loop. Myers is another name for parietal, correct? Or is it? Yeah, I think that's right. Or is that temporal?
I think temporal.
Myers is temporal. Okay, because there's another name for parietal too, but well, that would make sense.
B.
Say that again.
I think it begins with the B, but I can't remember the name.
Yeah. Okay, so it makes sense. So Myers must be temporal because watch this. So the upper aspect of the eye correlates to the lower of the upper outer quadrant correlates to the lower inner quadrant of the retina. Okay. Now the lower part of the retina, the lower quadrants are going to go to the temporal lobe. All right. So anything below the midline, anything on the lower aspect of the eye is going to go to the temporal lobe. This is this fiber here. I remember temporal lobe is lower than the parietal lobe. So the lower aspect of the retina is going to go to the temporal lobe, also known as Myers loop. And remember, the lower aspect of the retina correlates to the upper aspect of the eye. So that means that the lower aspect of the eye correlates to the upper aspect of the retina. And if it's in the upper aspect of the retina, it goes through the parietal loop. Okay, so go from the retina. If it's the lower aspect of the retina, it goes to the lower Myers loop or temporal loop. If it goes to the upper aspect of the retina, then it's going to go to the parietal because it's higher up. Just remember it like that. And just make sure you flip it when you get to when you get to the eye. The Lord could not have made it more difficult for us to see, to us to figure this out, right? I don't know, it's very confusing. Also, very importantly, when you talk about sparing of macular vision, I forget exactly what it was that you spare, isn't it? It's something.
So isn't
something
like supplied by two different nerves? So if you get rid of the oculomotor, you spare it somehow?
I think
It's the
something
middle
at the-
cerebral artery.
Yes.
Yep.
Okay.
It's
Okay.
what's in that paragraph. Yeah.
Okay, perfect. Yeah. Okay, good. So definitely remember that. Yeah. So if middle cerebral, what ends up happening is when you get to NB2, they talk about the actual place in the occipital lobe. It's like the cuneus or something. That's not important. What you need to know now is, yeah, middle cerebral artery. So if that's intact, you get macular vision. So you have central vision. Okay. So keep that in mind. As for eye movements, we kind of discussed this. Right. Yeah, again, this is that same test, right? So this is a good slide to look at to try to get your orientation. When you look out, what you're affecting. When you look in, remember the obliques are flipped when you look nasally. Oh, that was pretty cool. If y'all haven't done this, y'all could play around with that. Y'all don't have time for that, but whatever. Yeah, remember there's three components to cranial nerve 3. You have the ptosis, the eye's down and open, and the eye is dilated, unopposed sympathetics, right? All right. This got really tricky. I think y'all deal with the PPRF and the fibers next, or do y'all do that now?
No, it's this exam. Well,
damn it.
It was for us.
I wish I'd.
But this is kind of big, guys.
It is. I'm really sorry. I wish I had time to have looked at this beforehand, because this is tricky, but give me a second and I'll work it out in my head. Okay. So so first of all, when you talk about an nystagmus, they define it by the rapid phase, which is also confusing because then the problem is the slow phase, but it's defined as by the fast phase. So if you have fast saccadic movements back to the left, that slow phase is where the problem is. Okay, so the PPRF, if we are looking, okay, abducens, okay, so, right, so the oculomotor is going to look inward. It is going to tell, or does it go the other way? PPR.
For this one, it switches sides. So the left side of the brain tells like the body or the eyes to move right. So the left side of the brain goes to the PPRF, to the abducens, and then that tells the right eye to abduct. And then the MLF fiber always follows. So it goes PPRF first to abducens, so the right eye moves right.
Okay.
And then the MLF fiber on the left, because it's the left eye, that's what follows.
Okay, I had a little mnemonic too to try to remember this, but I don't know where exactly it is. But so oh God, and then the red glass test. Wait, there was a trick to remember this too. And then they corrected it there. So if you have a problem with the MLF, you can't, you won't have inward gaze, right? So if the abducens looks outward, the oculomotor can't look inward with the gaze, right? So like the patient is able to gaze to the right, but when the patient tries to gaze to the left, the right eye cannot abduct. So that's that was what I remembered. Okay, so wherever the injury is, so it's the right eye, wherever the injury is, that's the MLF that's affected. That's how I try to remember it. So if you look outward, you abduct correctly with this eye, but the right eye cannot adduct. that means it's a right MLF problem, right? So we can look at it back here. That's PPRF was there. So like, right. So you see the MLF crosses over. So the problem would have been on the right side. Did he go through this again? I swear I had more notes on this. No, I guess not.
So it's basically that the MLF lesion prevents adduction of the eye ipsilateral to the lesion.
Ipsilateral to the lesion. That's perfectly said. Right. Okay. So if you have a problem adducting the eye, right, looking inward, say it's your right eye and you can't look inward when you try to look to the left, that's a right MLF problem. The MLF that is affected is on the side that cannot adduct, right? Because remember, you're looking outward, right? So if you look outward to the right and the left eye cannot look inward to go with the right eye, it's a left MLF problem, whichever eye is trying to look inward, right? Because you're trying, this MLF is trying to coordinate the eyes to look together. So first you take the abducens effect, right? And then it goes and then tells the oculomotor which way to look. So if you have an oculomotor problem, you're not going to be able to look inward. But if it's a PPRF problem, you're going to be locked in a central position, right? Because that's your horizontal gaze. Unfortunately, it just takes practice going through these. But just remember, wherever the side of the problem is the MLF that's affected.
For the red glass test.
Do you remember the trick?
Yeah.
There was a trick that made it so easy.
Because it's not easy when it's explained. When you have the double vision, when you do it, if they see red.
Not the red glass test. It's not.
Y'all didn't do that?
It's not in lecture 27 because I'm looking at it now.
Yeah.
Well,
I don't remember.
Tomorrow.
Y'all haven't done it at all?
We're doing it tomorrow, I think.
Oh God.
Oh,
Let's
okay,
give 'em-
tomorrow.
Go over it then, yeah.
Yeah. Tell them the trick so that.
Yeah,
'cause it's-
so if it's the red light, it's the right eye. If it's the white light, it's the left eye. And so that'll make more sense when you go through it, but they'll tell you what they see. And if it's red, it's right. Wait, was that the trick?
I can't
Or
believe
was
they're
it they
making y'all
said
do
in the
this
notes?
the day before the exam. It's wild. That's really not fair.
Yeah, we're still going through like the pupillary reflexes and the corneal reflex all tomorrow.
Oh my
Okay.
goodness. The pupillary and the corneal is the thing that we were talking about. They'll have a handful of questions, but once you get it down, you get it and it's easy. And so as long as you spend 5 to 10 minutes on it, you'll be fine.
So like okay, I think I remember the trick. Okay, so if you're looking, okay, so first off, they put a red light over your right eye. They're looking for diplopia. So if your eyes can converge correctly, you should see one pink light. If they don't, that means if you see two lights like you see here, a red and a white light, that means the eyes aren't lining up. You have some sort of diplopia. So they put a red light over your right eye and they just leave your left eye alone and they tell you to look in a direction. And it gets really tricky to understand this, but the trick is that, so if you're looking to the right and you see two lights, okay, whichever light is the most to the right, like is the furthest to the right, is the eye of the problem. Okay, so let's take a look here. If we put the red light over the right eye and we tell the patient to look to the right, the light that is the furthest to the right to the way we're looking is the one with the problem. So the white light represents the left eye. I'll say that again. I know y'all probably trying to jot this down or remember it. So whichever direction you're looking, the light that is furthest to the direction that you're looking, furthest away, is the eye with the problem. The red will correlate to the right eye, the white will correlate to the left eye. Okay, so for instance, let's look to the left with this, right? If we're looking to the left, the light with that is furthest to the left is the red eye. Red eye represents the right eye. That's the down and dirty quick trick. I don't know if I ever really learned how the thing worked. I was just went with that, and it worked out fine. Here's what I was looking for. Yeah,
I just went
go
through
ahead.
our slides for tomorrow. We like they don't cover like the red and white eyes.
Okay, yeah. Then don't. Maybe I'll do it next for NB2. Yeah, don't even worry about it then. Thank you.
I want to mention though, it's listed in the learning objectives. So the last slide is literally 13 slides, which is learning objectives, and it says we'll share the slides later, and it says the red glass test.
That's dirty. That's dirty. Yeah. Yeah,
So
for real.
learn the trick. The trick is simple, and you'll get it right on the exam.
Yeah. Red, so red for right, right? Red,
Yeah.
right?
Yeah.
So whichever way is furthest is the eye of the problem. The eye of the problem. All right, here's the slides I was looking for earlier. Okay, so now so MLF, it's like all like flooding back to me, all these bad memories. All right, so if the patient is looking to the left, right? Ideally, they're gonna give you, hopefully they give you the left and the right. So on a lot of these, not on the scans. Remember, the scans are always flipped. You're looking at the patient. But for these cartoon images, they should give you these. So you're looking to the left, right? Abducens, we're good. Now the abducens has to tell the oculomotor, the medial rectus of the right eye to look inward. So as was mentioned earlier, you cross over. So if this right eye cannot look inward, it's a right MLF problem. The left abducens communicates to the right MLF to tell the right eye to look inward, okay? So just keep that in mind, because they're gonna ask you, they're gonna say patient looks to the right, the left eye, it cannot go past center. Where's the lesion? MLF on the right. Same side as the problem. All right, let's look at the PPRF. So this is conjugate gaze. So both eyes are gonna get locked in one direction. So let's see. So we're trying to, okay, so the patient is able to look to the left according to this arrow, but when the patient tries to look to the right side, they're not able to do it. What does that mean? The patient cannot, so patient cannot look to the right. That means you have a right PPRF lesion, down and dirty, right? Now, what's the difference between this and an MLF? MLF is gonna be unilateral. Okay, one eye can't look inward. PPRF, both eyes cannot look a certain direction. Which direction are they looking? If they're looking right, then it's a right PPRF. Okay, so same as MLF. Wherever the patient can't look with the defective eye is the side with the lesion. So one more time, MLF lesion, one eye cannot look inward. So if it's the right eye that can't look inward, it's a right MLF. Makes it easy. PPRF, if both eyes can't look to the right, like here, can't look to the right, it's a right PPRF, but it's both eyes, okay? So you can look one way, like to the left, but when you go straight and you try to look to the right, you can't go anywhere past midline with both eyes. So MLF unilateral, PPRF bilateral. The side that you can't look towards is the side that has the lesion on it. Now this, okay, so basically, I don't know if they'll actually test you on this, but if you think about it, what this means is one eye can look outward, and that's it. Okay, so this patient, okay, so it says left and this arrow works. So this patient's left eye can look outward, okay? But when this patient tries to look outward with the left eye, the right eye cannot look inward. That means the right eye cannot adduct, so that's a right MLF problem. Okay, now we tell the patient to look left. The patient cannot look left with either eye. I'm sorry. Let me correct that. We're trying to look right, as in the picture. So when we try to look right with both eyes cannot look right. That means it's a right PPRF. So this patient can literally only move one eye. It can only abduct one eye, abduct, move outward, one lateral rectus. Okay, so sit with this and try it, make sure you can work it out. But just remember, wherever the problem is with the eyes correlates to the sidedness of the lesion. I believe, is it cranial nerve? They talk about this too. Doesn't cranial nerve 6 run right by the MLF? For some reason, I feel like that was
6 or 4.
I think it's 6
3
because
for MLF and 6 for PPRF.
say that one more time.
3 for MLF and 6 for PPRF.
Okay, so yeah, okay. So remember that if there's some sort of
That's important, guys.
some sort of PPRF problem, cranial nerve 6 is in the area. Okay, so they could ask, I remember if there's some sort of infarction, it may be for the next test, but just keep in mind that cranial nerve 6 runs close to the PPRF, which kind of, well, no, it doesn't really make sense, but yeah, that's fine. Just remember that. And hopefully this makes sense to you. Remember, whichever way the patient can't look correlates to the side of the lesion. All right, I think we're good with that. Let me just check. Is this a question? Oh, cool. All right, I got a question. Let me see. Let's try this one. Thank you for sending that, Michael. Let's see if it'll load up one. May take a second. Is that all of the eye stuff? Did y'all have any more? Oh, we'll do the reflexes too. Here it is. All right, let's take a look at this one. 47-year-old woman comes to the physician because sudden onset double vision. H-test shows deficiency in adduction of the right eye during convergence test of both, when both eyes, during the convergence test, both eyes adduct. Which, yeah, so convergence means come together, right? So if they can converge, that means they're able to come together. So H-test shows a deficiency in adducting the right eye. Where's the problem? Would y'all say right MLF? Do y'all agree with that? Because we're worried about the adducting eye. The adducting eye, once unilateral, cannot look right. So we're referring to the right MLF. I don't have the correct answer. If y'all look, I mean, I think that's the right answer. Do y'all agree?
I thought it was F. Because
Is it F?
if you're both, because the convergence test shows that both eyes can adduct, so that's why it wouldn't be an MLF.
I didn't think convergence correlated. I thought it was.
So if both eyes can converge when you have an MLF lesion, it's just that like that specific pathway for adduction is impaired.
Because the PPRF can stimulate the MLF, right? So it's just saying that the MLF can't be stimulated by itself, but the PPRF can tell the MLF, oh, you can still do this, so it'll do it. As opposed to like the medial rectus muscle, if that was messed up, then there would be no convergence, like they wouldn't be able to do the convergence test at all, right?
Well, okay, so my rationale here is if both eyes can adduct, so medial rectus is intact to some degree, right? Which structure is damaged? So they can adduct, so the muscle's intact. I think the question's saying adduction of the right eye. So it's like,
the only thing this is testing us on is whether we know that convergence can ignore an MLF lesion.
Right, which is true, correct?
Yes.
Because I mean, yes. Okay, so this is this is what we're looking at here. Yeah. So right. So right eye cannot look inward. That's what it says here. H-test shows deficiency in adduction of the right eye. Convergence test, both eyes adduct. If both eyes adduct, then the medial rectus, we're good there. But the right eye cannot, when trying to, yeah, deficiency in adducting the right eye. So you're telling the person to look to the left, just like this. And you can't adduct the right eye. So this is a right MLF lesion. Okay. So now what if they said, well, you told the person to look to, you tell the person to look to the right and neither eye goes that way.
Wouldn't that be PPR?
Right? Yeah, exactly, right? So you tell the patient just like this. Patient can look to the left. Now you tell the patient to look to the right and both eyes lock on midline. They lock up. So you can't look to the right. So if both eyes can't look to the right, It's a right PPRF. Okay, so that's a good question right here. So first thing you need to determine is it unilateral or bilateral? Unilateral is MLF, bilateral is PPRF. Now, then you say, well, what's going on? Right eye cannot look inward, so it's a right MLF problem. If it was both eyes, whichever side you were trying to go to, it would be PPRF. All right. Thank you for sending that question. That's a good one. If y'all have any good questions doing the corneal or pupillary light reflex, like the ones with the charts that say, dilated or stuff like that, y'all could send those and we could try to determine, we'll try to look at those. Lindsey, maybe you could see if you could find an old one. Lindsey, are you not paying attention to me?
I nodded my head. I was yawning though.
Okay, maybe you could see if you could find one of those corneal reflexes where it says like you touch the right eye, the left eye doesn't move. You know what I'm talking about.
Yeah,
All right.
I do.
All right. In the meantime, let's try to look at some of the ear stuff. Ear, it's not terrible testing wise. So the general principle is air comes in, it hits the tympanic membrane, and this is an air-filled cavity. Because of the physics behind it, you have a large area here and a small area here. When you look at where the stapes attaches to the inner ear canal. So this is fluid filled. This has endolymph and perilymph. And so air hits here, these move, the little bones of the ear move, and then the fluid moves in here. And when the fluid moves, it moves the hair cells, which is insanely crazy to think that that's actually how the movement of the hair cells is how we process sound. So I'll try to point out a few things that were important. This slide was definitely on our exam. I remember this one. So trying to orient yourself. So it's actually just like this. Yeah, it's just like this. So this is the external acoustic meatus, or the ear canal. And then you could kind of see a little, so this is the EM, you could kind of see a little part of the bone, the malleus and the incus, and then the stapes is going to connect to the oval window. A good thing to point out, I think this may have been what was tested, the different nerves. The vestibulocochlear nerve has two branches. One, the vestibula, goes to the vestibule, the inner ear canals, and that has to do with balance, right? The semicircular canals are oriented in an X, Y, and Z axis. And by doing that, when the fluid moves, it kind of can tell you where you are in space. Now, the cochlear nerve attaches to the cochlea, and that's how we process sound. So I'm just going to go through and try to point out a few things. Definitely important. The perilymph is in the bony labyrinth, and the endolymph is in the membranous labyrinth. You do need to know the concentrations. I think it's coming up. I think endolymph is like, here it is. Perilymph is like ECF, so high sodium, right? Endolymph is like ICF, so it's gonna have high potassium. Definitely know that. This was a little tricky. I don't think they really ask about this. The hair cells. This is important. No, it's not. The other one, the one with the organochordy, is important. But yeah, I would probably know this too. So the different areas of the vestibular system. Then this is important too. The crista ampullaris has to do with angular momentum, right? Moving your head side to side, shaking your head no. So that has to do with this crista ampullaris of the semicircular ducts. Whereas shaking your head yes has to do with the macule and or the utricle and the saccule, right? So this is gravity and linear acceleration, right? So moving up and down. So definitely make sure you know the difference here, because they could test that. And
I have a question.
Okay.
Whenever you're ready.
Oh, okay. Yeah, we'll go through the ear stuff and then we can do the reflexes. Thank you. So this is super important. So this orientation of this cartoon is the same as this image here. So the scala media is going to be the area of endolymph. the scala vestibuli and tympani are going to have the perilymph. So and you could see the organ of Corti here. So that's important too. So basically, this membrane just kind of bounces up and down, and the differences in concentrations or consistency or viscosity of the fluids between the perilymph and the endolymph helps to move this basilar membrane of the organ of Corti. And when it does that, it moves those hair cells. So definitely know that the scala media, they could put this image on there, this histology image. Scala media is going to be where that endolymph is. And the helicotrema is the very apex. I think there was a picture. Oh, here's a better picture of that, right? So scala media is going to be the endolymph. Stria vascularis, definitely know that that's where the endolymph is produced. It makes sense because it's just right along inside the scala media. And then this basilar membrane, that's what kind of bounces up and down. That helps these hair cells move. Yeah.
What about the three
Right.
types of cells in the stria vascularis? He just literally, or Dr. Hargrove, I guess it's she, just like
No.
said there's three types of cells
Yeah.
and just kept going.
No.
Okay.
Nah, I don't think you need to know that.
Osmosis has a really good vid for this too, FYI.
Okay, so yeah, so look, this is what happens if you take the cochlea and you know it's wrapped up, right? It's bony and it's wrapped up. If you stretch it all the way out, this is what it would do, right? If it wasn't folded up. So the helicotrema is the very end point. So the high-pitched sounds, like tympanic sounds, are going to be think of them as lower energy. They're higher hertz and they're going to be absorbed early on. Down at the helicotrema is like bass. Like you could imagine bass, how much energy it has. It's absorbed way down at the helicotrema, right? So just think of it more energy, but bass correlates to a lower hertz. Tympanic sounds are higher hertz, but you definitely need to know that the bass goes further. Then, of course, the difference is here. Sensory neural hearing loss is complete. Oh, I'm sorry. Did y'all do Weber's and did y'all do that?
Today.
Yeah, today.
Yeah.
Okay. Oh, we could do that. No worries. So conductive hearing loss is something problem with the conduction of sound. Sensory neural hearing loss, you're done, right? Like if you lose the nervous signal from your ear to the brain, you completely lose that side. Conductive hearing loss, a lot of times it can be fixed. It's some sort of problem. Let me see if we could talk about that. It's actually not terribly bad. When did auditory? Maybe it's there. Okay, let's do this real quick. I think this was Haig. Yeah, whatever. I don't know. Take it as you will. There's no words. There's no words. Love this guy. Yeah, maybe some of the clinical correlates here. Yeah, the sinuses and stuff. You can ask about that.
Is this the one that says gross anatomy and development in the ear?
Yeah.
On what slide is 8, 9, 10, 11, slide 11, where it says the auricle, make sure you know that distribution of the nerves. They will ask that.
Right, so auriculotemporal is from the mandibular or the third branch of the trigeminal. And posterior aspect of it comes from the greater auricular, what comes from the cervical. This is very much a NB2 stuff, but it's fair game for this test. Unfortunately, I like the way, we had it the same way as you guys, but they used to teach cranial nerves first. That seems more easier to process than learning like the function and then going back and learning the cranial nerves, but it is what it is.
Anytime they mention innervation, please highlight it, make a note of it, because they like to.
Yeah. So anything in the external acoustic meatus, the external canal, auriculotemporal, right, branch of the mandibular, or the trigeminal, right, the mandibular branch of the trigeminal, B3. Chorda tympani is a branch off of the facial. It ends up, I see, we're mixing stuff. I don't want to get too in depth because y'all do this a lot in NB2, but chorda tympani actually does taste fibers, but it travels through the middle ear canal. What we should look at is that that box we were talking about. Where is that at? Is that on this lecture, Lindsay?
That's in the next lecture.
The next one. Okay, we're gonna look at that.
He started talking about it, I think, today.
Okay, we'll look at it in a second.
37.
Okay. All right, here's the chord of tympani. You see, it is a branch of the facial. It's just interesting here because it travels through that middle ear canal, but it ends up doing taste fibers. Yeah. Okay, here it is, but yeah, it got a lot of red highlights on it. I think he has here it is. That's the better picture. Okay, so let's orient ourselves. So this is like you're the doctor looking directly into the ear, okay? So the part that you're looking directly at, like this outside of the box part that's kind of pulled away to where you could see the middle ear, the outside of this is the tympanic membrane. So this box should be covered by the tympanic membrane. It's not here. So that should help you orient yourself. When you look completely through, that's the posterior wall. Okay, so that's going to separate it from the oh shit, hold on. Any tympanic membrane. That is right. Yeah, it must. Lateral wall, that's this wall. Okay. Yeah, so the wording's kind of trippy, but like lateral wall is the wall you're looking at. Medial wall is the wall in the back. Okay, so it's like you were looking in the ear. So the outside that's pulled away is the tympanic membrane. The side all the way to the back is the posterior wall. You can see the oval window there, right? That helps to connect to the inner ear.
So if this is labeled the way it is, then that medial wall is in the back, but there is also a different posterior wall, which is to the left.
Posterior wall, yeah, posterior wall will be on the back side.
Okay.
Back side. So sorry, I might have said that wrong. Yeah, so medial wall is back here. You see the line. So lateral is what you're looking in through the ear, right? Lateral is going to be the tympanic membrane. Medial is this back wall, right? That's where the oval window is. Posterior is going to be on the back side, right? And that connects to the mastoid air cells. That's just the little bony parts in the back. And then knowing where the vessels run is going to be important. So the anterior wall, it also has the auditory tube, right? Where you hold your nose and you can equilibrate. The auditory tube, pharyngeotympanic tube, it's on the anterior side, and it's also on the side with the carotid artery. Floor, the jugular vein is going to run below it. Okay, so that's where you can orient yourself. We could do it again. So imagine you're looking at the otoscope into the ear. You're looking directly like you're looking right now at this. The part that's pulled away is the tympanic membrane. That's what is accessed from the external acoustic meatus to the middle ear canal. So you pull that away. The wall furthest to the back is the medial wall. That's going to separate the middle ear canal to the inner ear. Okay, and you see the oval window there. Posterior wall is going to be on the back side, the posterior side. So that's going to be where the bone is, where there's like back here, if you could see where my pointer is. Posterior wall is going to be like back here. And anterior wall, remember that the auditory tube or the tympanic tube is on the anterior side along with the carotid artery. And then the floor is going to be where the jugular vein runs. Okay.
How are they actually going to test us on like this?
I'm pretty sure they asked us one of the vessels was what they asked, like what side the vessel ran on.
The floor is high yield because of the jugular vein.
Yeah.
Yeah, right. So yeah, so the floor is the jugular, and then the carotid artery is going to be on the anterior side, and then the auditory tube is on the anterior side as well. I think that's what they asked. They just asked what area of this box one of the vessels ran, like the carotid artery.
Like one of the grades questions was talking about that, and they said that like if you have a tumor in the on the floor area or something like that, it would put pressure on the jugular, and then you will have a backup of blood.
Okay.
Another,
Yeah, that
Like,
makes that makes sense.
anything with respect to any major structure, if you have damage to any one of the borders, you can impinge a surrounding structure. And so that's really important.
Yeah. So definitely the vessels, know the tympanic membrane's anterior side. The medial wall is going to lead to the inner ear. And this outer part that you're looking into, which is the lateral side, is where the tympanic membrane is. And you can actually see this, the facial nerve actually travels in through the posterior side too. So add that as well. Yeah, that should be good for that. Let's see, all of this and that, this wasn't really important. Okay, let's take a look at this.
There might have been, is there, might be an NB2 thing, but there's an ear embryo thing where there's like a tiny opening, like a duct opening, like behind post-auricular.
Isn't that the one that's opposite? The one you think is supposed to be, it's like on the right side, but it's this thing. Hold up, let me find this thing.
It's like an opening. Yeah, I think they tested us on that.
But it's weird, right? Because like this is the right ear, but it's a left preauricular sinus. Don't ask me what that means. I just know that on the right side there's a left sinus.
Wrote it down.
But,
I think they tested us on that, FYI.
It might have been. It may have been even a picture actually, or maybe it was this one.
Oh yeah, the arch first
yeah.
group. Yeah, that's why it's important. That's why I remember it. Y'all will get more into the
sinuses.
grooves and arches in NB2, so don't pay attention to that for now. But if it's referenced here, that's probably this is high yield.
I know y'all learned that y'all had DLAs on the arches, and y'all have those same DLAs again to review for NB2.
It's not a big thing in NB1 at all. I think it's just with respect to named defects that they focus on. Now, when you get into NB2, we'll go into that big, but don't really stress for it for your, at least that's how it was with us. They didn't focus on it in NB1.
But just to clarify, so like the most superior one is a pre-auricular, and the inferior one is like an auricular sinus, or they just both
think it matters.
No, I don't think it's defined like that. I don't think this has to do. I don't think pre-auricular has to do with this. I think they're no. I'm sorry, they are. No, that's a pit and a sinus. I don't know. I have no idea actually. I think they're different, but don't quote me on that.
Yeah, he just said what they were and then kept on going. It's like, okay, cool.
Incomplete fusion of primitive tubercles. I wrote it here too, so maybe they are the same.
So does the pit deepen into a sinus and then the sinus gets inflamed?
That's a question for Dr. Haig. I have no idea.
The biggest thing is that it's a thing. It's incomplete fusion of the primitive tubercles, and it's a remnant of the first pharyngeal group. That's what you need to know for this exam.
I remember
What's highlighted here?
The sinus becoming a cyst.
Yeah, I mean that makes sense if it closes off. That would make sense. That sinus would become a cyst. Yeah, but what's highlighted here, I think, is what's testable. If y'all are still confused, y'all might want to contact him. It's. I don't know if I listen to the guy's lectures. It's tough when there's nothing here to look at. But anyway, all right, let's try to look at these. Right, we kind of talked about these again. Scala media, remember that's endolymph. That's more like intracellular fluid, high potassium. Right, the perilymph is more like extracellular fluid, high sodium, and you can see that here. It's got a star. All right. Inner hair cells are the more important ones in my, as I understand it, because that's the majority of how sound is transduced. And then you can amplify the signal with these ones on the outer side. I don't think they really got into too much detail about the positive and negative.
It had one or two questions, but all you needed to do was correlate it with the test, the cold water test, but they didn't really go
Oh,
into the
man.
actual physiology of it. It's just, do you know what the test tells you?
Did y'all do that yet? The cold water thing?
Tomorrow.
You looked
Tomorrow.
you look
Oh my
towards, okay, so it's really tricky because the way they taught it was in a comatose patient. So watch out for that because it's opposite in a patient that's not comatose. Okay, this is what happens. I believe, Liv, did you look towards the cold water or? Yeah, okay, I'm sorry. That's right.
It depends if it's cold or if it's warm, because warm water, one of them settles, one of them rises. And so it will depend on the direction it moves the hairs.
It's cold water. I remember thinking somebody put cold water in my ear. I would look to see who did
Okay,
it.
where were all of these acronyms when I was doing NB1?
I don't know. They're just, this is all just, I don't know where this information is coming from. I don't know. But look, it's in a comatose patient. So if you put cold water in their ear, they're going to look to the cold water. If you're not comatose, your eyes kick back. You're like, it's not a nystagmus, but your eyes will correct. The point is, if the patient's comatose, they're able to look towards the cold water, but their eyes won't be able to come back to midline. Okay, and then if it's warm water, you look away from it. So remember, if it helps you remember in a comatose patient, cold water, you look towards why the person put cold water in your ear. Okay, but it's tricky because, like I said, they teach it as if you're comatose. So that's just how they do it. Because some of the mnemonics that they have out there, like in first aid, those correlate to an awake patient, an alert patient. So the mnemonics are backwards. So be careful with that. If they teach a comatose patient, learn it that way. So here is when this is not, oh yeah, 16 killer. Okay, yeah, so this is like the helicotrema. Okay, so down the cochlea. This is high pitch sounds, low pitch sounds like bass go all the way to the end. They have more energy, but remember it's tricky because bass sound goes to the end, but that's the apex of this. So don't think of it like that, right? That could throw you off. The base of the base of the cochlea is where high pitch sound is. Deep sound, like you would think of as bass, goes to the apex, right? So don't let that confuse you. The base is where the high pitch sound goes. The apex is all the way at the end where the low pitch sound goes. Okay, and you could see that here. Yeah, this was tricky. Apex is where the low frequency goes. High frequency is like here, where the high pitches sounds go. Don't even worry about this. Lord have mercy. Yeah, I don't know if this, do you remember this, Lindsey?
Yeah,
The outer
I
cells.
don't know if, I think there was, yeah.
Yeah, it might have been a practice problem. Don't look at this. The only point of this is if you have a central vestibular cochlear lesion, you probably won't get hearing loss, right? It has to be a peripheral nerve because there's so much crossover. Okay, so it has to be a peripheral nerve. But if you do get some sort of peripheral nerve lesion, you'll get sensorineural hearing loss on that side. So you'll get unilateral hearing loss. It's one of the rare ways you can get unilateral hearing loss. It has to be the peripheral nerve before it gets to the brainstem. Yeah, so, right. It's cochlear nuclei or cranial nerve 8. That's the only way you can get unilateral hearing loss on the ipsilateral side. Once it gets to the brain, there's all kind of crossover. So y'all learn this, Broca's areas. Yeah.
Weber's and Renz's.
Okay, here we go.
Important.
Is this next? Okay.
Yeah, conductive.
So the way I think of conductive, like if you hold one of your ears closed and you hum, you hear it better in that ear, right? In the ear you're holding it down. That's like a conductive hearing loss, right? So if you have some sort of conductive hearing problem, you're going to hear the sound, the Weber's test, better in the ear that's blocked. Okay. If you have a sensorineural neural hearing loss, it's complete loss. So you're obviously going to hear it better in the other ear. He just did Weber's? He didn't. Oh, never mind. Sorry. Okay. And then you do the Rennie's test, and then bone conduction. So air conduction should last longer than bone conduction. So you do bone conduction first, and then when patient can't feel it anymore, you put it close to the ear and see if they can hear it. Okay, so if air conduction is greater than bone conduction, which it should be, that would mean the test is normal, right? If you hear it better, bone conduction, right? Bone conduction will bypass the conductive process, right, of going through the ear canal. So if you hear bone conduction better than air conduction, that's indicative of a conductive hearing loss. So if you did Rennie's test and you got this, like you got bone conduction better than air conduction in the right ear, if you did Weber's test next, which side would it lateralize to? Well, the side with the problem, right? So the right ear, right? So I think actually it's easier to do Rennie's test first and use Weber's test as confirmatory, even though they always present it the other way. I always do Rennie's test first. So let's just do that again. If you have bone conduction better than air conduction in the right ear, meaning you put it against the malleus in the back, malleolus or malleus, and then you couldn't hear it in the air or was decreased overall, you would get a conductive hearing loss. So if it was on the right side, if you did Weber's test after, you would expect to hear it better in the side with the problem. Sensorineural hearing loss is going to be always going to be to the other side. And then if air conduction is less than bone conduction for one side compared to the other, that would indicate sensorineural hearing loss. So you kind of just have to do practice problems with these. But like I said, if you do Rennie's test first, a lot of times you can get the answer and just confirm it with Weber's test. So we could just do this real quick. So if you have Weber's test lateralizing to the left, you have two options, right? You either have a conductive hearing problem on the left or a sensorineural hearing problem on the right, which it says here. So then bone conduction, hearing loss on the left, right? So that should be, so it lateralized to the left and you have bone conduction greater than air conduction on the left. That would indicate that you have a conduction problem on the left. Hope that makes sense. Did he give another one? No. And then, yeah, so this would be indicative of, what's up?
Quick question, could you please go over again why when you close your ear for a hearing defect, you hear louder?
Yeah, so if you close your ear, you're basically artificially producing a conductive hearing loss. The conductive process is going through your ear canal. So if you just hold your ear closed like that and you hum, you can actually hear it better in the ear you're holding. So that's the same thing as a conductive hearing loss. So that sound is going to lateralize to the ear with the conductive problem, like this. So if she has, what's her name? That's I forget her name. The actress. It's funny.
Natalie Portman.
Natalie Portman. Yeah, I know, it's kind of funny that she's on here. But anyway, all right. So if it lateralizes to the left, if you have a conductive hearing loss in the left, like you were holding down your left ear, you would hear it better in that ear, right? So that would be to the left. Now, if this was a sensorineural hearing loss, it would lateralize to the right. So let me tell you what I'm talking about when I like to do the other one first. So if you do Rennie's test and it says bone conduction greater than air conduction, so that immediately tells you that you have a conduction problem on the left side. I'm sorry. Wait. Did I skip one? Conductive hearing loss on the left. Yeah, I'm sorry. Yeah, that's right. So bone conduction greater than air conduction is conductive hearing loss on the left. So after knowing that, you could say, okay, well, what happens in the Weber test? It should. So you know if this is the case, if this is a conductive hearing loss in the left, you know that Weber's test should lateralize to the left, which it does. Okay, so a lot of times, if not always, Rennie's test will give you the answer, and you can confirm it with the Weber's test. Do you remember this, Lindsay, or was it just practice problems?
Yeah, no, there was like one question on the exam. I'm trying to find if I wrote this trick down in my notes, or because it's actually really simple. There's a threshold, and if you're below the threshold, then
I think if the lines separate, it ends up being conductive, and if the lines stay together, it ends up being sensorineural. But I could be wrong. I think that was one of the tricks.
Tom explained this to me because I didn't know what I was looking at. But there's a threshold at the top, and I think if you go below it, it's just like
it'll tell you here. Yeah, this will tell you like how severe it is. But if you look at, like, I just think if I remember correctly, bone conduction, if the lines separate like this, it's indicative of bone conduction or a conductive problem.
presbyacusis on that last slide, know that term.
Yeah. And if they stay together like this, it's indicative of some sort of sensorineural hearing loss. Yeah, presbyacusis is high frequency hearing loss. It's often seen in elderly patients. Okay. We could finish up with this stuff. Right, so, oh goodness. Oh God, this is gonna have to come back to me. So is this what we were talking? Oh God, this is if the patient.
Oh my God.
This nonsense. So if you move the patient's head, your eyes should stay straight, unless they're in a coma. Y'all are doing this tomorrow? We might confuse y'all more than.
I have some questions if we want to do it for the reflex testing.
So this is defining the nystagmus, like I was saying earlier. They define it by the fast phase, but the fast phase is the corrective phase. The problem is always the slow phase. So you're looking for the slow phase. Okay, here we were talking about the cold water. Remember, cold water, you look towards the cold water, right? So these are comatose patients. And yeah, this is what they were talking about. So cold water, you look, comatose patient, you slow drift to the side of the cold water, to the right. Because they're comatose, the eyes don't snap back. You don't have that reflex. Okay, so what's important is that the cold water being cold, it's an inhibition of this process. Think of it makes the fluid colder, so it doesn't move as fast because it's colder, right? So it's inhibition, and that'll make you look towards the cold water. Warm is excitation, hot water, it's warm, so it'll make you look away from it. Okay. Now remember, these are comatose patients because, like I said in first aid, the mnemonics they use are for patients that are awake, so they're actually opposite, so don't use those. Right, so yeah, if you have no baseline, okay, again, it's side of the lesion, right? So this is the same thing with MLF or PPRF. You're gonna look towards like PPRF or an MLF. If there's a problem looking in one direction, that's the side that has the problem. Same thing here, okay? The eyes are gonna look to the side of the lesion, okay? So actually, let me correct myself. The MLF and PPRF, you won't be able to look in the direction, right? So if the right eye can't look inward, that means you have a right MLF problem. If both eyes cannot look to the right, that means you have a right PPRF problem. So here so maybe just jot notes on this. If you you always look towards the side of the lesion. What does that mean? That means the slow phase is toward the side of the lesion. You look towards the lesion. Fast phase is what your reflex is kicking back to normal. So let me just, I know I confused myself there. So if you have an MLF problem, it's going to be one eye. So if you're not going to be able to adduct the eye. So if the right eye cannot adduct, you have a right MLF problem. PPRF is both eyes. So if both eyes can't look to the right, you have a right PPRF problem. Vestibular ocular reflex, if you have a lesion, the slow phase is going to look towards the side of the lesion. Now, what if they tell you the nystagmus here? They're going to tell you you have a leftward nystagmus, right? But that's the fast phase. That's the snap back, right? That's not defining where the problem is. The problem is always the slow phase. So you're going to look towards the lesion. You're going to look for here. Make sure you notice that this is left and right. So you're going to look towards the left, slow phase to the right, and then you're going to have a leftward nystagmus, right? Sorry, let me say that again. Here, it's on the left. So you're going to have a slow phase to the left, and you're going to have a rightward nystagmus. So they'll define that as a rightward nystagmus because that's the fast phase, but it's a problem with the slow phase, and the slow phase is looking to the left.
So
okay.
Nystagmus is characterized by the reset, not the pursuit.
That's exactly right. Yeah. And I think back in the day, they didn't know what the hell was going on. So they were like, let's name it by the fast phase. But the fast phase is just you correcting what the hell's going on. So your eyes are drifting and you have to be like, whoa, get back. You know, you're like, whoa, get back. Right. So they're defining it by that fast phase. But the problem is that initial slow phase. Why are your eyes deviating? So wherever the eyes deviate, that's when you're going to look toward the side of the lesion. Yeah. So be careful because they'll tell you a leftward nystagmus in the stem, but you need to know it's that slow phase, that to the right, that's the actual problem. What's up?
Is it safe to say that for like eye lesions, wherever like the eye is drifting to is the side of the lesion?
Drifting. Well, the only thing we really talked about is the MLF and PPRF, and it's not necessarily a drift. It's the fact that they can't look towards a certain direction, right? I don't know if are you talking about you're talking about in this reflex then? Yeah, this reflex. Yeah, correct. Yeah. So whichever way the eye's drifting. Yeah, you're exactly right. Whichever way the eye's drifting, that's our slow phase. That's the side with the problem. So slow phase, problem on the left, but then you're going to get a rightward nystagmus to correct it. If the patient's comatose, you won't get that nystagmus back because the reflex isn't activated typically. So you're looking at the slow phase. Yeah, exactly right. Whichever way the eyes tend to drift, right? Cold water, it's going to drift to that side. Lesion, it's going to drift to that side. Warm water, it'll drift to the other side. Okay. Yeah. Oh, this is like that optokinetic tape stuff. So I think this is the idea. Like I think they use the example if you're like riding in a train and like you're looking at the landscape and your eyes like they zoom in on or they focus in on a point and they keep kicking back. That's referred to as the optokinetic reflex. So you're going to follow the target to the right, and that'll be the right side of the reflex. And so you're looking outward, right? So this right eye is looking outward as it's moving, and then you're going to kick back. Okay, that's all they're talking about here. But I believe it's specific to the temporal lobe is where this reflex is. Parietal occipital eye field. Sorry, it's parietal occipital. I forget what has to do with the temporal, but let me say that again. Parietal occipital eye field is the optokinetic reflex, right? So you're kind of drifting outward and then you kind of snap back, like if you're looking at a moving target. And that's what they use this tape for. You look at one line and you keep looking at the lines and focusing in as they move them. All right. Let us look at this real quick. Okay, so the direct response is going to be cranial nerve 2, right? So that's the input to the eye. So the input to the eye is going to not only tell that eye to dilate, so it's going to tell the sympathetics to dilate the eye, but it's also going to send a signal to the other eye to dilate as well. So they're going to ask you certain problems, like if you shine a light in the eye and this eye and the eye you're shining the light in doesn't dilate, but the other eye does, the eye you're not shining in, that's a consensual response. What does that tell you? That tells you that this eye is accepting light. It sees the light, right? Cranial nerve 2 can tell that there's light being shown in the eye, and it's able to tell the other eye, yes, dilate. So that means there's a motor problem in the eye you're shining the light in. Okay, so let me say that again. If you shine the light in this eye, how can you tell the sensory fibers work? Well, you can look at, because it has to tell the other eye to dilate as well. Now, if you shine the light in this eye and this eye doesn't dilate and this eye doesn't dilate, that means there's a sensory problem. The sensory fibers in the eye that you're shining the light in have to be intact to tell the motor fibers to work, right? So if you shine the light in one eye and the other eye dilates, but this one doesn't, that means there's a motor problem in this eye. If you shine the light in this eye and neither eye dilates, that means there's a sensory problem. So it can't tell this eye to dilate and it can't tell the other eye to dilate as well. Okay, so they can ask you a lot of different variations on that. What's up?
Just wondering, you keep saying dilate, and I'm wondering if you mean constrict.
Sorry, yeah, not same thing. Yeah, exactly, right. Constrict, right? If you're shining the light in it, obviously the eyes are going to constrict. Yeah, so constricting of the eye. So again, if you shine a light in there and the eye constricts, then you know the sensory fibers of that eye and the motor fibers are intact. If you shine the light in this eye and the pupil doesn't constrict and the other pupil doesn't constrict, you know there's a sensory problem because these sensory fibers are what travel to the other eye to tell it to constrict. If you shine the light in this eye and this eye does not constrict, but the other eye does, you know the sensory fibers in this eye work because it was able to tell the other eye to constrict, but the motor fibers here are not working. So you have to define it by sensory and motor, and they'll give you all different scenarios. But basically, you're looking at the sensory aspect of it by the consensual response. Okay, so if the sensory fibers are intact, it should produce a consensual response in the other eye, unless there's a motor problem in this eye. So they'll give you different scenarios. You shine a light in the right eye, you shine a light in the left eye dilates, right eye or constricts, right? So you need to, do you have a question on this, Lindsay, that we could look at?
Yeah, I have two.
All right, you could send it to me.
Is this what they mean? Is this what they mean when some of our practice questions are like they're doing a swinging test?
A swinging? Oh, like swinging
the
light. Yeah, okay. They'll do that just because it's supposed to be like a rapid, or they'll swing like just in one eye, in and out of one eye, just to see if you get this rapid response.
Yeah, that's just pupillary response in and of itself, I think.
And you can do that in one eye and look at the other eye at the same time, right? So you can see if the other eye is kind of like dilating and constricting. All right. So Lindsay was obviously a scribe. What we got here? 17-year-old girl comes to the doctor with complaints of 7-day history of headache. Neurological exam is performed. Corneal reflex. Oh, we didn't do that one yet. Okay, well, it's the same principle with corneal reflex. So opposed to the eye constricting and dilating, you're talking about touching the eye. So the sensory fibers for touch of the eye are the trigeminal nerve. The motor fibers that's going to make the eye blink are the facial nerve. Okay, so it's the same principle. If you touch one eye and neither eye blinks, you have a sensory problem in one of the eyes. If you touch one eye and the other eye blinks, it's a motor problem or facial nerve problem. Okay, so let's see. Okay. Left direct without right consensual. Absence of right, but reserve. Okay, whoa. Okay, so the left direct works. So does the left motor work? Yes, right? Because the left direct has to work for you to blink. And the right without right consensual response. So some sort of, so it's either the sensation going to the right or it's a motor on the right. So let's see, it also shows absence of right direct, but with the preserved of the left consensual. So it looks like we have a right motor problem. So the motor is facial, so it should be right cranial nerve 7, I believe.
Hold on. It would have been nice if I wrote the answers down.
Okay, so let's try this again. So let's check our motors, okay? So left direct works, so left motor works. You don't get a right consensual, so we can't confirm the right motor works. Okay, so let's do touch the right eye with no response, no motor response, but preservation of left consensual. So the sensory fibers are the consensual response is working, right? So when the left eye's touched, it's telling the right eye to move. When the right eye's touched, it's telling the left eye to move. The left eye moves on its own, so motor's working. So it looks like the right motor is the problem. So that would be B, yeah, right cranial nerve 7. So remember, cranial nerve 5 is going to be sensory. Cranial nerve 7 is going to be motor. Now, the pupillary light reflex works the same way, except you're using cranial nerve 2 and cranial nerve 3, right, for dilation and constriction. Let's see.
What's the next question?
Try the other one. 23-year-old man is brought to the ED, motorcycle collision, 1 hour. What does that mean?
Prior to arrival.
Prior to arrival. He has facial cutes and
facial
fracture.
cuts and fractures. Sorry. I can't type.
I thought that was some scribe talk I didn't know about.
No.
Okay, transected right optic nerve. Okay, we talked about the optic nerve. So what is that going to affect? The sensory to the right eye. Okay, so if there's no sensory to the right eye, can you have motor to the right eye? No, because it's not going to recognize it. Can you have any response in the left eye? Well, no, because the sensory to the right eye is not working. Right, so direct and consensual response have to be absent. No input is coming into the right eye because cranial nerve 2 is out. It has no idea there's even light shining in it, right? So it can't tell its own eye, the right eye to constrict, and it can't tell the left eye to constrict because there's no sensory, innervation. Okay, I hope that made sense, but understand if you can get down the pupillary light reflex, you can definitely do the corneal reflex. Just remember the difference is for pupillary light reflex, cranial nerve 2 is input, cranial nerve 3 is output. For the corneal reflex, cranial nerve 5 is input or the touch, and cranial nerve 7 makes you blink. All right. Yeah, same thing here. So, right, so you touch the eye, trigeminal nerve should feel it, and it should tell this eye to close, and it should also communicate to the right eye to close as well. And you'll get into this more again with the nuclei and stuff in the next exam. Let's take a look here. Okay, so patients, I labeled it here, the patient's looking at you, right? So you shine a light in the right eye and there's no constriction, and there's no constriction in the left eye. That immediately tells me that, well, there's no sensory input to the right eye. Why isn't the left eye closing? Unless the left eye has a problem too. Sorry, we need to go fully. So no response in the right eye. Now the left eye does work. So immediately from this information, one thing you can definitively say is motor on the left works, right? We could say that's intact. Now, does sensory on the left work? Well, yeah, because the right eye closes. Does motor on the right work? Well, yeah, because the right eye constricts. So the problem is this sensory in the right eye. Okay, and you can see that here. Right eye sensory's out. So everything works properly when you shine light in the left eye, right? Left eye is supposed to constrict. That's motor. Sensory's intact because it constricts and it tells the right eye to constrict. Right motor's intact because the right eye motor constricts, right? So oculomotor. Now, when you shine it in the right eye, there's no sensory input. So it's not going to constrict. And that makes sense because the left isn't constricting either. So the sensory is very important when you look at the crossover, the consensual response. Corneal reflex. Okay, so if you touch the right eye, you get a response. So the eye blinks. So sensory and motor works in the right eye. Now, the consensual on the right eye doesn't work. So it looks like there's some sort of communication problem from the right eye to the left eye. Or let's try this. Left eye, no direct response. So here, does the left eye, left eye has no response, but consensual works. So the sensory arm works here, right? When you touch the left eye, cranial nerve 5, the trigeminal nerve, is working because it told the other eye to blink, but it didn't blink. So that tells you there's a left eye motor. You just have to work out these problems and then you'll get faster at them. But it is important that you get both eyes before you come to a conclusion, because sometimes I try to jump the gun. But yeah, so hopefully that helps. If somebody wants me to go over it again, I can, just let me know. So y'all haven't, no, this is tomorrow, sorry. Okay, yeah, you always look to the side of the lesion. We talked about that. If you're gonna look away from it, he's looking away here. That's gonna be warm water, right? You look towards the cold water, unconscious. Let's see here. This is a good one. So we put warm water in this ear. So you expect both eyes to look toward the other side. Why is the left eye not looking inward? Because there's a left MLF problem, right? It's one eye, it's unilateral, it can't adduct. So the left eye can't look inward, so it's a left MLF problem. That's a good advanced question. If you can work through this, that's a good testing point. Make sure you know these angiograms. Your first look at this, you should be able to tell this looks like it's the carotid artery, not the vertebral, right? Because it doesn't have that central basilar artery. So you could see the MCA coming off and the ACA going midline, right? And then, I don't know, this is something about the tape. I don't know, y'all will go through this tomorrow. So I know it's getting late for people. So, right, yeah, but y'all will go through these questions tomorrow. I think that's pretty much, this was more of the same. Yeah, this is more of that cold water reflex and the cold and the hot water. You remember, you look towards the cold water or you look towards the lesion, the slow phase towards the lesion. And then actually this, are y'all doing this? This tomorrow?
Yeah.
Okay,
Yes.
This is really good. Definitely pay attention to this one. This is a good representation of what the test questions will be like. But being able to differentiate these, yeah, I learned a lot from this one. That's all we really have. If y'all have questions, by all means, we can go through stuff. I know it's a lot.
Hey Brady, I do have a question. I'm still kind of like lost in regards to that pupillary reflex, if you don't mind going.
Okay, sure. So when you shine the light, let's say you shine the light in the right eye, right? You would expect the right eye to constrict and the left eye to constrict. So when you shine light in the right eye, the sensory aspect is going to tell you that there's light in the right eye. It's going to tell the motor portion, cranial nerve 3, to constrict the right eye. And it's also going to communicate to the left eye to constrict. Okay, so that consensual response is important to see if it can communicate to the other eye. So you have to do the problems and try to differentiate if it's a motor problem or if it's a sensory problem. But if you shine a light in one eye and it constricts and the other eye does not constrict, you don't get a consensual response, then obviously, that would be a motor problem in the other eye. Sorry, it's hard to do these because they give you this whole vignette, right? But just make sure you try to differentiate the sensory arm or the sensory or cranial nerve 2 to the eye, the direct and consensual response, and then the motor aspect to both eyes. And yeah, we're fading quick. I'm dying. The test was rough. It was tough. Yeah. Make sure you know your rashes, because that's fun. Yeah.
Would rather know rashes than neurobio at this point.
No,
Yeah,
you won't.
You tell me that when you get to
would.
rashes. I didn't know how many rashes you could possibly have until we took this.
Well, and they're
test.
all
Lord
so
have
similar too. It was so vague.
God. If everybody was vaccinated, we wouldn't even have had a test, so we would have been fine. But anyway, all right. Any other questions? I'll post this video as soon as it gets compiled. Well, good luck on y'all's exam. Y'all could reach out to us tomorrow or whatever if y'all have any other questions.
Charlie would definitely appreciate dog treats.
Yeah, there were a lot of track questions. There really were. It seemed like it was definitely skewed towards the tracks. So make sure you can orient yourself left and right and double check your work if you have time for sure. Try to mark them, scratch them off, or strike them out as you go, and that'll make it easier.
The lecture with all of the PNS, or not necessarily PNS, but where it like blocks off the little people with blue, that's super high yield. Where it like colors in the little people, and it's like lesion in the cortex, lesion in the IC, lesion here, and it like the people are blue. I'm not making any sense right now.
The one with the dermatome map and each different type of lesion.
Yes.
Okay.
That's
the other
very
thing-
high yield. I'm sorry. I have exam brain. I can't form a sentence.
Do they include like they kept putting these like cartoon images that I know you guys had for like the medulla and pons and like different parts of the brainstem? Do they include any of those on the exam? Because those have been like freaking me out in the lecture.
A cartoon? I don't remember.
You don't really need to know the nuclei, right? Like all the different nuclei,
Yeah,
but
no.
just know like if you have a lesion to like the anterior spinal artery, like know what deficits that'll encompass. Right, so everything on the anterior side, that 2/3 that's supplied by everything basically besides the dorsal columns, right? So know if there's those deficits, but y'all will get into the nuclei for the next test. And y'all didn't do like Wallenberg syndrome or anything yet, did y'all? That's next test. Y'all did do that. No.
Yeah, they've done PICA.
Oh God, yeah. So like that, that's an example. Like know that compilation of symptoms, and you'll be able to answer the questions. Yeah, stuff like that, because it has to do with like pica infarcts and anterior spinal artery and stuff like that. But you won't like have to. They won't give you like first order, like pointing to a nuclei and asking what it is. Just if there's some sort of lesion, yeah, what would be the symptoms? Cool. All right, I'll go ahead and stop the recording then.